Now we're going to talk about the care of the patients with infectious respiratory problems. And the first one that we're going to go over is rhinitis. Rhinitis is inflammation of the nasal mucosa. It's a common problem of the nose and often involves the sinuses. And it can be caused by infection, usually viral, but it can be bacterial or any contact with any allergens. Allergic rhinitis is often called hay fever or allergies, is triggered by hypersensitivity reactions to airborne allergens, especially plant pollens or molds. And your acute viral rhinitis, which is also called coryza or the common cold, is caused by over 200 viruses. It's spread from person to person, droplets. We've all had colds, viruses. We've all had some form of rhinitis in our lives. Remember that colds are most contagious in the first 2 to 3 days after the symptoms appear. The colds are very self-limiting unless we have a bacterial infection that's involved with it. Complications most often occur in immunocompromised, immunosuppressed people and older adults, especially if they live or work in a crowded condition or in a group setting. Interventions include our drug therapy such as antihistamines, decongestants, antipyretics, and our antibiotics. We have to be really careful with our antihistamines and decongestants, especially in our older adult, because of the side effects such as vertigo, hypertension, and urinary retention. So we have to be real careful with that. Our antihistamines, the leukotriene inhibitors, and our mast cell stabilizers block the chemicals released by the white blood cells from binding to receptors in the nasal tissues or reduce the amount of mediator present, preventing that local edema and itching. Decongestants basically constrict the blood vessels, decrease edema. Antipyretics are given if fever is present, and antibiotics are prescribed only when a bacterial infection accompanies rhinitis. Rhinitis can also be caused by overuse of nose sprays or drops. It's basically because of a rebound nasal congestion from overuse of those drops. So steroid nasal sprays may be used also to decrease the rebound that they may have with nasal congestion during the first week after discontinuing the drug, because they may have that rebound rhinitis after they discontinue the drops or the nasal sprays. So we can also, and all of us have tried this before, the complementary and alternative therapies such as coldies or large doses of vitamin C, echinacea, Zicam. And usually these products will help increase the nonspecific immune function. Supportive therapy makes sure that the patient rests at least 8 to 10 hours a day, has fluid intake of at least 2,000 milliliters per day, and humidify the air, helps relieve congestion. Teach the patients to hopefully reduce the risk for spreading the cold or the rhinitis by washing their hands, especially after nose blowing, coughing, rubbing their eyes or touching their face. And also stress the need to avoid close contact with people who are most susceptible to infections, such as older adults, infants, and anyone who has a chronic respiratory problem. So usually an uncomplicated cold typically will subside within 7 to 10 days. Okay, we're going to continue. We're going to continue now with sinusitis. Acute sinusitis is a symptomatic inflammation of usually greater than one of the paranasal sinuses, usually of less than 4 weeks duration, resulting from impaired drainage and retained secretions. Because rhinitis and sinusitis usually coexist, and we talked a little bit about that in the other slides. The preferred term of this is called rhinosinusitis. The disease is subacute when symptomatic for about 4 to 12 weeks and chronic when symptomatic for greater than 12 weeks. It affects about 31 million individuals in the United States. It remains the 5th leading reason for prescribing antibiotics. And the incidence is highest in the early fall through the early spring. Adults usually have 2 to 3 viral URIs per year, and 90% of these colds are accompanied by a viral rhinosinusitis. So our risk factors is a virus or upper respiratory infection, allergic rhinitis, asthma, cigarette smoking, dental infections and procedures. There's some anatomic variations that can cause it, such as a deviated septum, a cleft palate in children, tonsillar and adenoid hypertrophy. Another risk factor is immunodeficiency and cystic fibrosis. Our general prevention of this is the same as for rhinitis, is hand washing to prevent transmission of viral infection. So some of the pathophysiology for this is there's inflammation and edema of the sinus mucosa, obstruction of the sinuses, and then there's impaired mucociliary clearance. Secretions that are not cleared become hospitable to bacterial growth, thus inflammatory response, the release of cytokines and neutrophils damage that mucosal surface. And under our etiology, we have it's viral, vast majority of cases, usually rhinovirus, influenza A or B, respiratory syncytial virus, adeno, corona, and enteroviruses that can cause it. Bacterial is complicates the situation, more likely if symptoms are worsen after 5 to 7 days or do not improve greater than 10 days. And the organisms that are involved are H. influenza, M. Cardialis, and strep pneumonia are the most common, or staph pneumonia, after often overdiagnosed, which leads to that overuse of and increasing resistance to antibiotics. Sometimes you also see a fungal etiology with our patients with sinusitis, but these are basically seen in our immunocompromised type individuals. Diagnosis is usually done through the H&P. Exam suggests and establishes the diagnosis. On the history, we'll see worsening of symptoms greater than 5 to 7 days after the initial improvement, especially this is with bacterial sinusitis. Persistent symptoms for greater than or equal to 10 days, persistent purulent nasal drainage, unilateral upper tooth or facial pain, unilateral maxillary sinus tenderness or fever. So you can see that these kind of symptoms after that initial viral infection, if those symptoms are worsening, then we're going to see that purulent nasal discharge, that maybe some tooth pain, facial pain, and more systemic type symptoms such as fever. We also will see with this headache, nasal congestion, maybe some retroorbital pain behind the eye. Maybe you'll see ear pain. Maybe they'll have halitosis, bad breath, or they may have a chronic cough. When you see symptoms such as visual disturbance, or the patient brings it to your attention, the visual disturbance, or especially diplopia, double vision, if there's any altered mental status, that's something that requires urgent attention. So on physical exam, we're going to be looking for fever, edema, redness of the nasal mucosa, any purulent discharge, any tenderness to palpation over the sinuses, and the physician or the nurse practitioner may even use a transilluminal illumination of the sinuses to confirm that there's fluid in the sinuses. So our treatment under medication, our first line treatment is decongestants, pseudoephedrine, and some nasal sprays such as Afrin. But you have to warn the patient not to use those for greater than 3 days. Remember that they can have that rebound rhinitis. We're going to treat with analgesics, acetaminophen, aspirin, NSAIDs, maybe codeine for some severe cases, antibiotics. Sometimes, remember, we're going to look for that worsening of symptoms greater than 5 to 7 days with the antibiotics, and we usually treat them for 10 to 14 days if we suspect that it is a bacterial sinusitis. So usually we start off with some broad spectrum antibiotics such as amoxicillin or Septra or doxycycline, depending what their allergies are. Oral antihistamines such as Claritin, Allegra, Zyrtec, Clarinex may be used. Chlorotrimethrin, Benadryl, Singulair, nasal steroids such as fluticasone can also be used. There are some second-line medications, Augmentin, high-dose Augmentin, Ceftin, Biaxin, Levaquin, and some of our general measures that we want to include as nurses is that we want to include hydration. It is very, very important that we keep our patients well hydrated when they have sinusitis. Tell them if they think that they've drank enough, then they need to drink some more. Steam inhalation 20 to 30 minutes 3 times a day. Saline irrigations, the neti pot or nose drops. Sleep with the head of the bed elevated. Avoid any exposure to cigarette smoke or fumes. Avoid caffeine and alcohol, just because of the diuretic effect, and it can dehydrate you. Antibiotics only when findings suggest that there's a bacterial infection. Analgesics, NSAIDs are important. It's usually a self-limiting type of disease, and usually antibiotics should not be used unless it's gone over and you see other persistent symptoms, usually for greater than 10 days, and those worsening of symptoms 5 to 7 days.